having Dr. Isha Agrawal. So you can start.
A very good afternoon to the members of the jury and to the respected audience. So I'm Dr. Isha Agarwala and my topic is a reverse algorithm for Müller's muscle resection surgery for ptosis correction. I have no financial interest to disclose. The aim of this study was to evaluate the surgical outcome of Müller muscle conjunctival resection, MMCR surgery performed with a reverse formula. But what exactly is reverse and what is MMCR? So to talk about what exactly is reverse, the Müller's muscle is a smooth muscle that is sympathetically innervated and elevates the eyelid by 2 to 3 mm. Conventionally, a phenylephrine test is used to stimulate the Müller's muscle and to evaluate the outcome of performing a MMCR surgery. But in this, we are doing a MMCR procedure without performing the PE test in mild ptosis patient with a good LPS activity, providing enough evidence that phenylephrine test is not entirely necessary to perform a MMCR surgery. So is reverse good? Well, we'll see. Because reversing in size is amazing and reversing to old music tracks is also good. So we'll see about the surgery. To understand what exactly is MMCR, we first need to understand how does the Müller's muscle help in ptosis correction. To look into this, we first have to know the Müller's muscle anatomy. So Müller's muscle is located in the posterior part of the eyelid. As we see in this image, the yellow portion in the diagram shows the LPS muscle. The purple portion shows the tarsus and the red portion shows the Müller's muscle. So basically it is placed in the posterior part of the eyelid. So in ptosis, conventionally we have two diverging schools of thoughts, which is the anterior approach and the posterior approach. In this we are going to perform the posterior approach, and in this study we had a total of 14 eyes with mild ptosis without performing the 2.5% phenylephrine test with good LPS activity more than 10 mm. Mild ptosis patients of 1 to 2 mm ptosis and LPS more than 10 mm were enrolled. The patients were recruited from Oculoplastic Surgery Department of Drishti Netralaya and Vivekanand Netralaya. Prior history of oculoorbital, eyelid or eyebrow surgery, trauma, any systemic disease were excluded. So how much tissue to excise? The amount of excision was 9 mm when the ptosis was 1 mm and 10 mm was resected when the ptosis was 1.5 to 2 mm. In the surgical technique, we first use a Dimas retractor to evert the eyelid and the posterior surface. A predetermined amount of Müller's muscle and conjunctiva was measured and marking was done. From the superior border of the tarsus, a Putterman's clamp was placed and the sutures were passed and the tissue was resected. So coming to the results, in this study we had 14 eyes of 10 participants, out of which 6 were females and 4 were males. The mean standard deviation of age was 35 plus minus 15 years. 7 patients had aponeurotic ptosis, 3 patients had a congenital ptosis. The mean preoperative LPS function was 12 plus minus 2.6 mm. The mean conjunctiva resected was 9.46. So in this, the amount of tissue resected, 9 mm was in 4 patients, 10 mm was resected in 6 patients. The mean MRD1 was statistically significant in the first, third and 4 months post-operatively. Post-operative symmetry where MRD1 within the 0.5 mm of the fellow eye was achieved in 9 patients. No overcorrection was seen. So this was our first patient where the patient had mild ptosis, both the eyes, LPS activity was 12 mm. In post-operative period, good correction was obtained. In the second patient, mild ptosis in the right eye, LPS activity was good, good correction was obtained. In the third patient, we had a mild ptosis in the left eye. We did a MMCR, 9 mm and good correction, contour maintained. The last patient was a congenital ptosis. So coming to the end, MMCR is a less invasive procedure causing no damage to the orbital septum and the fat pad, especially in patients with deep superior sulcus. The posterior approach provides less tissue dissection, absence of cutaneous scar and shorter operative time. So for resection, we used a formula similar to the study in Perry et al. In Ophthalmic Plastic and Reconstructive Surgery Journal for correction of ptosis. 9 mm was the baseline amount resected, which was added or subtracted according to the MRD. So the mechanism that we postulated here was vertical posterior lamellar shortening causes the secondary contractile cicatrization of the wound and advancement of the Müller muscle LPS complex to the tarsus. We excluded LPS less than 10 mm because with weakened aponeurosis, if the weak fibers were transmitted to the tarsal plate, no force or strength would be transmitted, hence no elevation. The disadvantages were we excluded the dry eye patients with ocular surgery disorders, resurgery is difficult to predict and perform. Thus, I would like to conclude by saying MMCR is an alternative procedure in patients with mild ptosis and good LPS. Procedure is less invasive with low complication and reoperation rate. Thank you.
Thank you, Dr. Isha.